Pleasure to talk to you about this topic, about the target blood pressure controversies during chronic kidney disease. So as I have no disclosure, so as you know, the hypertension is the most common comorbidity during chronic kidney disease, and it represents in stage 4 and 5 about 80% of the patients. So it's a strong and independent risk factor for development of chronic kidney disease and progression to end-stage renal failure. Hypertensive kidney disease is the second most common after the diabetic nephropathy. So we have to tackle this hypertension in order to avoid the events on the cardiovascular and the cardiovascular risk. Hypertension is a typical consequence of many primary and secondary kidney disease. Thus, high blood pressure is by far the most common modifiable factor for chronic kidney disease. Blood pressure target recommended by guidelines improve a lot the cardiovascular risk and the renal outcomes, but it remains some controversies in the guidelines we will see altogether. So as the core of the pathophysiology of hypertension associated with chronic kidney disease, we have the common element is the hypertension, which is in the center, as it is the cause for renal damage, for diabetes mellitus, for hypertension, and for obesity. So all these components lead to hypertension. So if we want to improve the cardiovascular risk and the renal risk, we have absolutely to reduce the hypertension in order to delay and reduce end-stage renal failure and its progression, and the cardiovascular events as well. So the question is about what are the goals for the control blood pressure in this population, and what measure we have to do in order to perform to set a good treatment for these patients. And you have to perform also the proteinuria and urine tests. So the paradox of blood pressure during CKD, why is lower blood pressure is not always the better? So because one shoe doesn't fit all, so we have to see later on why these discrepancies. The G-curve phenomenon is also present in some studies, so we have to settle down and see what's wrong. When aggressive blood pressure is lowering, maybe increase mortality. So if we want to treat the patient right, you have to balance to make a balance between the kidney protection and cardio protection as well. So accordingly to the different trials, we see that there is a tight link between hypertension and chronic kidney disease. So as you see in this chart, the blood pressure, when it is going up, the risk is very important. So you have a common continuum down if you reach the blood pressure of 120. And the same here in the Asia Pacific region, the same constatation. You have always the link between hypertension and the risk for events depending on the blood pressure. So this study is very important, as it shows that the risk is very important whenever there is the high blood pressure in this population. And the study which is important, or the trial, is SPRINT, from which derives this kind of blood pressure as a target 120, and it showed that there is less cardiovascular events, less stroke, less myocardial infarction, heart failure, cardiovascular death. But people are not, all of them agree about that statement. So there are the ongoing trials later on concerning CKD with stage 4 or 5 for a follow-up of 3 to 4 years, and with the low blood pressure to target is the mean blood pressure, and here it is less than 130/80. And the end point is about renal failure. So after this, to make the story short, no evidence of superiority of intensive therapy, laurin, in this case, for preventive progressive of chronic kidney disease. So when we take the population of diabetes, we saw also that whenever you reach less than 130, you have more benefit. than 135. So in this population, it's a subgroup which benefit from intensive treatment, but without reaching 120. What is the impact of proteinuria? On this slide, you have many trials which are summarized here, and they show that at the baseline, when you have no proteinuria, there is no effect if you set an intensive treatment for hypertension. And the benefit is for those who have at the baseline proteinuria. So is it proteinuria only? Even the ratio albuminuria over creatinine, whenever it's more than 0.22, you have the risk is important. So you have to intensify the treatment in order to avoid the kidney injury or end-stage renal failure. And there is a summary of 7 or 8 trials which are dealing with proteinuria. And here you have the level is 1 gram. So whenever the proteinuria is less than 1 gram, you see that the reference group is here. So if you have the proteinuria less than 1 gram, there is no need to go below 150. So the benefit is in this side, in this range between 130 and 140 millimeter Hg. If you have proteinuria which is more than 1 gram per day, at this time you see that the level must be around 120, 130. This is the best where we have the benefit for intensive treatment. And if you go up for more than 160, the risk is very important. And lower than 110, it's more important also. So that's why some guidelines was given in order to set like a statement for each patient. And you see the CKD, which is launched in 24, but based on the data of the 2021. And for all patients with hypertension and chronic kidney disease, they recommend less than 120 millimeter, but the recommendation is a little bit weak. Whereas the European Association in 2023 for all patients is less than 140/90 with a strong recommendation, and they prohibit the target of less than 120 millimeter Hg. And you see the other guidelines, it's about 130 to 140. So there is no, it's not permanent. And for Asian countries, it's about the same. You have less than 130/80 in patients who are at high risk. That means diabetics, chronic kidney disease, albuminuria. So it's almost 130. So how to reconcile these guidelines? We have to harmonize relevant guidelines in order to give to the clinician just one paper where he can rely on, in which he can rely on for the benefit of our patient, and proposal to limit disagreement by setting a holistic approach. That means nephroprotection and cardioprotection as well. And the main target must be around less than 140. So if you go further for whenever you are intensive, for this patient, you see for the progression to end-stage renal failure, you see the plateau or the nadir where we have no event. It's between 130 and 140. When you are less than, there is no big damage for the kidney. But if you see, it's the G curve, but if you see the mortality, you see that it's very important whenever you are less than 120. It's the U curve phenomenon. That means that you don't have to go below. And the benefits of intensive lowering, if we want to apply this intense lowering blood pressure, you have to pay the toll because there is hypotension with derived symptoms and the events. So if we want to, for the patient to adhere to treatment, to have a good quality of life and to have more survival, you have to get and to assess frailty of these patients. And also the phenotype of CKD matters because there are a lot of patterns of chronic kidney disease. So the non-proteinuric, diabetic, the proteinuric. So all these patients have to be assessed. And the role also of the ambulatory, because when we have office blood pressure, it's not accurate. So if you want to monitor this patient with chronic kidney disease, you have to perform an ambulatory blood pressure. And you see here, the blood pressure at baseline was okay, but during more than 1,000, you have almost, most of the patients have masked hypertension. So all the patients has to perform this this kind of device in order to set the treatment accurately. As a conclusion, the blood pressure reduction is the most relevant treatment to reduce the rate of GFR decline and also cardiovascular events. Cardiovascular risk in in CKD. Lower blood pressure goals and earlier control reduce the burden of CKD. Phenotype of CKD and comorbidity are relevant to decide the goal, the blood pressure goals. Blood pressure at goal around the clock, the monitor of 24 hours. And new therapies, SGLT2 inhibitors and denervation may be helpful. Rigid blood pressure targets are outdated, so we have to have an idea about the precision medicine is the future by artificial intelligence. So for overall, it's less than 130/80. For whenever there is proteinuria, the most popular number is less than 125 over 75. Thank you.